This video we are going to see about Pemphigus. So what is Pemphigus? What do you mean by the word Pemphigus? So Pemphigus is derived from the Greek word which means Pemphigus, which is nothing but bubble or blister. Clinically it can be called as vesicle or bulla. So based on the difference in their size, vesicle is 0.5 centimeter in diameter, a blister which is filled with clear fluid. If it is more than 0.5 to 1 centimeter in diameter, it is called as bulla. In oral cavity, we usually see vesicle rather than bulla. Bulla is main commonly seen in the skin. So Pemphigus is an autoimmune condition that is affecting the epithelium of skin and oral mucous membrane. So let's see the variants of Pemphigus. So Pemphigus can be classified into Pemphigus vulgaris, Pemphigus foliaceus, Pemphigus erythematosus and Pemphigus vegetans. So among which Pemphigus vulgaris is the most common one and it is most commonly seen in the oral cavity. So coming to the pathogenesis of Pemphigus, so before going into the pathogenesis, we have to understand the molecular structure of our oral epithelium. So the oral mucous membrane consists of oral epithelium and the lamina propria. So the oral epithelium consists of various layers starting from stratum basale, above which we have stratum spinosum, above which we have stratum granulosum and above that we have stratum corneum. So the cells within the oral epithelium are attached together, that is bound together by a component called desmosomes as we see in this picture, and the cells with the basement membrane is called as hemidesmosomes. So the desmosomes contains various glycoproteins, mainly desmoglein 3 and desmoglein 1. So in Pemphigus, the autoantibodies that is produced by the B cells targeting these desmosomal components, especially the desmoglein 3 and desmoglein 1 of skin and mucous membrane, resulting in split in the epithelium and resulting in blister to form. So in simpler terms, when the autoantibodies attacks these desmosomal components, the cells are no longer bound to each other. It drifts apart, resulting in formation of split within the epithelium and forming bulla clinically. Based on whether the involvement of desmoglein 3 or desmoglein 1, the pattern of Pemphigus disease varies. Because desmoglein 3 is preferentially seen in the basal and parabasal layer of the epidermis and oral epithelium, whereas in contrast desmoglein 1 is mainly seen in the superficial portion of the epidermis. So when the autoantibodies are attacking the desmoglein 3, we'll have manifestation in both skin and oral mucous membrane, and oral mucous membrane it is more prevalent. And if it is involvement of desmoglein 1 autoantibodies, the disease manifests more in the skin and less in the oral cavity. So based on these difference, the Pemphigus pattern of disease varies. Other than autoimmune diseases, sometimes a Pemphigus like oral conditions can be seen in patients who are taking certain medications such as penicillamine, angiotensin converting enzyme inhibitors and non-steroidal anti-inflammatory drugs. Pemphigus can also be associated with malignancy, especially lymphoreticular malignancy. Such condition is called as paraneoplastic Pemphigus. In addition, a rare genetic condition called as chronic benign familial Pemphigus or Early disease may also be reported in addition to the autoimmune pathogenesis. Coming to the clinical presentation of Pemphigus, usually it is seen in middle-aged adults of about 50 years of age, and patient usually complain of oral soreness, and on examination we could see superficial, ragged and denuded ulceration which is distributed apocytally on the oral cavity. Clinically, we do not see the intact bulla on the oral epithelium because the oral cavity is constantly under masticatory forces, chewing and swallowing forces. All these can disrupt the bulla, and also in Pemphigus, the bulla is more of friable and more of flaccid in nature. So it could easily get ruptured and forming ulcers. So usually the patient complains of ulceration rather than bulla itself. And the ulceration can involve any area including the palate, labial mucosa, buccal mucosa, ventral surface of the tongue, and gingiva can also be often involved. And along with that, we have to look for other areas like skin and conjunctiva. Sometimes conjunctiva is involved and it results in bilateral conjunctivitis, but it does not form any scarring. Like in case of pemphigoid, the lesions in the conjunctivitis can form scarring, which is known as symbolphron. But pemphigus, we do not have a scarring formation, but it can involve the conjunctiva. One characteristic feature that should be noted in pemphigus is Nikolsky sign. So when you apply lateral pressure at the normal epithelium or around the perilesional area, it results in new bulla formation. So what is the mechanism behind it? So already the cells are under immunological attack and the cells are no longer bound to each other. So when you apply force, it splits away or it slips away the layers of the epithelium and resulting in formation of bulla or vesicle. So this is the main mechanism of Nikolsky sign. So as I said, it's a characteristic feature, not a pathognomic feature. So we have to be very cautious. It can also be seen in other condition. So we have to rule out the other condition in order to diagnose the pemphigus. The diagnosis of pemphigus is confirmed by a biopsy. So the biopsy is usually taken from the normal epithelium or around the vesicle or ulcer, that is the perilesional area. So this is very important because when a tissue sample of ulcerated area is given for testing, then the results would be inconclusive because there is no interface between the epithelium and connective tissue layer. And also the important thing that we should note during biopsy is the transporting medium. For histopathology, we can use formalin, but the formalin induced specimen cannot be used for direct immunofluorescence. So for direct immunofluorescence, we need special transporting medium, which is nothing but the Michel solution. So if Michel solution is not available, we can go for liquid nitrogen freezing of specimen, or we can examine the fresh specimen within 4 hours. So these are the alternatives if Michel solution is not available. The histopathological features of pemphigus reflect the action of circulating antibody on desmosomes. So here in the left side, we could see the normal epithelium with the desmosomal junction intact. So the green color is depicted as desmosomal junctions, but in the right side we could see the autoantibodies that has been attacked the desmosomal junction, so that the cells within the spinous layer are drifted apart, so the cells are no longer bound to each other. This feature is known as acantholysis, and the loose cells which are drifted apart assumes a round shape, resulting in Zang cells, which can be identified with the use of exfoliative cytology preparation. And also mild to moderate chronic inflammatory infiltrate can also be seen in the connective tissue. Sometimes the entire superficial layers of epithelium are stripped away, leaving only the basal cell, which can be called as row of tombstone appearance. After histopathology, direct immunofluorescence is done to confirm the diagnosis. In direct immunofluorescence, tissue specimen is coated with fluorescent labeled anti-human antibodies. This will detect the autoantibodies that is bound to the desmosomal components, and which will appear as a fishnet or chicken wire pattern due to intercellular deposition of antibodies over the surface of keratinocytes. Treatment of pemphigus is based on the severity of the lesion. If only oral lesions are present, topical application of steroids such as triamcinolone acetonide, clobetasol cream is given, or intralesional triamcinolone is tried for lesions that is not responsive to topical application. If severe or along with systemic manifestation, systemic high-dose corticosteroids is given to achieve remission. Steroids are started with 1 to 2 mg per kg per day for 2 weeks, then tapered gradually to avoid the side effects of the steroids. For example, consider an average adult of 70 kg person prescribed with 1 mg per kg per day steroid, that is 70 kg per day for 2 weeks. Then after 2 weeks, it is reduced to 20 mg per day for each week until 20 mg is reached. Then that 20 mg is continued for 1 month, followed by 10 mg per day for 3 months, then 10 mg every other day for 3 months. Then finally 5 mg every other day is continued for 6 months as a maintenance dosage. All this is done to provide remission at high dose initially, then to avoid side effects, and also to prevent acute adrenal crisis due to HPA axis suppression, that is hypothalamo-pituitary axis suppression when the patient is under steroids. For recalcitrant cases, patients should be tried with pulse therapy where high dose of corticosteroids are given for a shorter period of time. Then if the patient is contraindicated for steroids, then we have to go with immunosuppressants such as rituximab and azathioprine. Other therapies also tried for severe disease conditions like immunoadsorption and plasmapheresis. Immunoadsorption is a procedure that removes specific antibody from the blood, and plasmapheresis is also similar to immunoadsorption where replacement of plasma could be done along with pemphigus autoantibodies can be removed. These are tried only as a last resort. Prognosis of pemphigus can be assessed by measuring the circulating antibodies with the use of indirect immunofluorescence and ELISA. And pemphigus usually undergo complete resolution, although remissions and exacerbations are common with pemphigus. Before the development of corticosteroid therapy, as many as 60 to 90% of these patients had died, primarily due to the result of infections and electrolyte imbalances. Even today, the mortality rate associated with the pemphigus is in the range of 5 to 10%, usually because of the complications of long-term steroid therapy.